This is Frequently Asked Questions about Natural Migraine Relief for Women, Episode 18, Hysterectomy and Migraines. Hi, Jeff Baker here again as your physician host for Frequently Asked Questions about Natural Migraine Relief for Women. I'll start this week's discussion by saying whether or not you have a hysterectomy is not the cause of having a migraine. It can, however, suggest some common hormonal root cause factors that could be promoting both uterine dysfunction and migraine headaches. By the age of 60, 1 in 3 women will either have a hysterectomy or have had it recommended to them. This includes procedures proposing removing the uterus only, or those including removal of the ovaries as well. The potential reasons for hysterectomy are many, and sometimes the procedure may be unavoidable for the management of cancer or precancerous lesions. The most common non-cancer related reasons for a hysterectomy include uterine fibroids, endometriosis, increasingly heavy, painful, or prolonged menstrual periods, excessive thickening of the uterine lining, also known as adenomyosis, and uterine prolapse. Ultimately, most hysterectomies are the end result of years of hormonal imbalance that, with time, adversely affect the uterus. The most common version of this imbalance is a condition we call estrogen dominance, where the excess influence of estrogen affects either uterine anatomy or its function related to menstrual periods. In most cases, it's not that there's too much estrogen, but rather too little progesterone to balance the estrogen that is present. This is also the case in many migraines, where hormones play a role. Estrogen dominance can be a strong promoting factor for migraine headaches in women, especially late in the monthly cycle or during perimenopause, if in either case progesterone output is suboptimal. If advice you've been given about considering a hysterectomy overlaps with the worsening of your migraines, that's a pretty good sign that you should take a closer look at the potential role of estrogen dominance in both situations. Some of the problems caused by estrogen dominance include irregular or heavy periods, migraines, mood changes, difficulty concentrating, weight gain and abdominal bloating, and hot flashes. It can also include breast tenderness and increased breast density over time, which can also make a self-exam or mammogram less accurate in early detection of abnormal changes. Also fatigue, low libido, insomnia, uterine fibroids, and fertility issues. Some of the symptoms we've just discussed fall into the latter portion of the menstrual cycle, and when this happens, they are loosely termed PMS or premenstrual syndrome. PMS falls into a portion of the monthly cycle that is particularly prone to progesterone deficits. If you have migraines and also have any combination of the previously listed symptoms, consider that they may be related. If you've also been told that you need to consider a hysterectomy for a non-cancer related reason, this should also raise a yellow flag on a potential chronic estrogen and progesterone mismatch. Of course, it's always best to recognize such ongoing estrogen dominance as early in life as possible and potentially lower the long-term negative pro-proliferative effects it can have on the female reproductive tract, including the breasts. Unfortunately, as the estrogen and progesterone levels can change dramatically on an almost daily basis through the cycle, doing blood work for these may not fully document an estrogen dominant condition. Self-charting your symptoms like mood, weight, fluid retention, PMS changes, headaches, and breast tenderness throughout your cycle can often identify where your progesterone may be running low. A simple yet underutilized strategy for estrogen dominance is to add a daily dose of USP progesterone on the at-risk days of the cycle. The use of progesterone is amazingly safe to the degree that you can buy it routinely without a prescription. I have seen the use of added progesterone reduce fibroids, adenomyosis, heavy periods, and even endometriosis over at times to the point of not needing a proposed hysterectomy. Having said that, I would always pursue a full measure of due diligence on your healthcare options with the final decisions about the management of your female health concerns made in consultation with your trusted medical advisors. Here is some general advice about the use of progesterone for estrogen dominance. It is available over the counter and by prescription. Over-the-counter versions give around 15 or 20 milligrams per serving. Many patients benefit, however, from the 30 to 60 milligram dose range, and long-term it may be more cost-effective to get these doses made up by a compounding pharmacy. If you buy them as a non-prescription, make sure the label says USP progesterone, not just wild yam or other plant extracts. These extracts are not always fully bioidentically active in humans. And if you use it as a cream, apply it in the evening and rotate it in application among your 4 extremities. I like to use the forearm or bicep area of the arm and the inner thighs in turn, using every area around every 4 days. Using the self-charting approach I discuss above, consider using a daily dose of topical progesterone during the most estrogen-dominant times of the month, which is oftentimes the latter 7 or 10 days of your cycle. You may benefit from finding a knowledgeable medical consultation on individualizing hormone therapy for either migraine or other estrogen dominance related problems. If you have a nearby compounding pharmacy, the pharmacists there typically know where to direct you. Managing estrogen dominance is only one of 90 non-drug therapy options I found useful for migraine headaches. If you would like to understand the broader range of root cause factors that drive your migraines and then individualize the many possible therapy options, you should take a look at my comprehensive Natural Migraine Relief for Women course with its unique migraine action plan system. See www.naturalmigrainerelief.online for more details.